So I will welcome everyone, and I'm sure we'll get some stragglers. I can't see everyone right now, so if I'm missing something in the chat, or if you have something to say, feel free to unmute and shout it out. I have presentation view going. Welcome to our fourth advisory group / committee webinar for the Social Data Sharing Collaborative. And I am going to ask everyone who has just signed on to please, in the chat, share your name, pronoun, organization, and role, and also tell us about an outdoor place in Oregon that brings you joy. If you're in town, maybe that's a park that you really like, or maybe it's just a favorite outdoor place, but we'd love to know. And for those of you that don't know me, my name is Courtney Kenny. I use she, her pronouns. I work at Oregon Primary Care Association as the Health Equity Manager. And an outdoor place that brings me joy is probably Forest Park. I'm not from Portland, so having such like a huge, beautiful park in town is really special to me, and I go there all the time. Angel's Rest, that is a really great hike. I like that one. Mount Tabor. Love Mount Tabor. Really good recommendations in here. You could take a whole vacation with these. I'm going to take us to the next slide. Thank you, everyone, for sharing. So I think everyone's super familiar with Zoom at this point. Here's some reminders. You can help avoid background noise by muting your line once you join. I see pretty much everyone has done that. Please share your camera when you're speaking. If you're willing to be seen, we would love to see you. The chat is available for comments or questions. And then also it really helps us for tracking if you rename yourself to include your organization name. And you can do that by right-clicking your name or right-clicking your box and selecting rename. And then also we are recording this session, and we don't post it publicly, but we like to be able to share with people who couldn't make it today. And then this work is only made possible through really generous funding from Cambia Health Foundation. So we're super thankful to Cambia. Our agenda for today, we just spent about 5 minutes settling in. I'm going to take 10 minutes or so to review the first 2 workshops and the objectives of this grant. I know not everyone has made every call, so that's an important thing to do. And then we'll spend 15 to 20 minutes going over the most recent webinar that we had as part of this learning collaborative. We heard from 2 providers that are Rhode Island-based F2HC on how they have used Z codes for predicting costs and utilization, as well as risk stratification. And then I'll share some plans for our upcoming May workshop that kicks off on Wednesday and runs throughout the month. And then we will do a Mentimeter poll. If you're not familiar with that, it's super easy. We love it as a discussion tool, but you will need to have a phone handy or be ready to pull up another browser on your screen. So as a reminder, the goal of the Social Data Sharing Collaborative is to create a space, a year-long space, to explore existing and alternative options for social data sharing between clinics and payers, specifically using Z codes, to develop a set of replicable questions and key partners to engage when embarking on data sharing efforts between payers and clinic. And we do have a working set of questions, which I'll show you in the Mentimeter later. To, in the long term, improve social data standardization across the health system, including integration opportunities with state or regional health information exchange efforts. And we did hear as part of Rhode Island's presentation how they have utilized their statewide HIE. So the organizations participating in this learning collaborative with CARE Oregon, we have Virginia Garcia and Wallace Medical Concern. With Columbia Pacific CCO, we have Reinhardt, and with Umpqua Health Alliance, we have Aviva and Adapt Integrated Healthcare. Of course, there were a ton of competing priorities this year, so we have had a few other organizations join as they're able, and those ones are Waterfall CHC, Lane County CHC, Northwest Human Services, and Pacific Source. And we're almost done with the year. We're in our last 3 months. So we've had 3 webinars. 2 of those we were learning from external states. In October, we heard from Pennsylvania about how they've incentivized Z codes. And in April, as I've shared, we learned from Rhode Island. We've had 2 workshops, one spanning July and August. The second one was in December. Throughout this whole year, our CCO and CHC teams have been meeting monthly to share data and work on their pilot projects. And then this is our 4th advisory call. In the first workshop, teams came together to establish their teams, roles, and work plans. Each team chose 3 to 5 Z codes to collect. Unsurprisingly, housing, income, and food were the most popular ones. They settled on pilot patient populations. Some teams decided to go right for universal screening across their whole clinics. Others decided to pilot with a smaller team of just 1 provider and 1 medical assistant, so it's pretty varied there. And then they also decided on pilot data sharing mechanisms between FQHC and CCO. The second workshop in December, they presented on the evolving clinic workflows that they have, including roles that are associated with social needs screening and documenting Z codes, the fields in the EHR that they're using, how they're using this information to inform care and inform care team decisions, and then also for community referrals. They shared on their data workflows, which I'll review again on the next slide. They told us about what the patient and community response has been thus far, and then also some challenges that are starting to creep up, including telehealth workflows with social needs screening, closing the referral loop, some technical issues with EHRs, especially manual reporting, as well as a lot of competing priorities for social needs data sharing and different visions for that work. Then we also heard about the importance of patient education and messaging around why this data is being collected and who it's being shared with from pretty much all of our teams. We asked them to explore different ideas for partnering with CCOs and what that partnership could look like. We heard CCOs providing more resources in their region, CCOs helping to build momentum and excitement with staff. Of course, incorporating this information into payment models and creating incentives, and then also assisting with screening on the ground. And we did have a few questions about that last time. Hopefully we'll hear updates on whether or not that team decided to pilot the CCO partnering with screening throughout the next month. And then I do like to call out who is actually documenting Z codes in the EHR and recording the social needs screening. It's mostly support roles such as community service coordinator, social work interns. We also have patient navigator and AmeriCorps patient navigator, and then medical assistants documenting this information. Here are the data sharing workflows as they stood in December. Really, it's broken up by CCO rather than FQHC, because the FQHC, the ones that are partnering with CCOs together are really using the same data sharing workflow with their CCO. And then I'll read the third one there in blue. So one example, a CHC, a report is pulled from the EHR, including both screening data and Z codes, and sent to the CCO using a flat file feed or an Excel sheet shared on an encrypted platform. The CCO adds the Z codes to claims on the back end and then uploads that to OHA. And they're also combining that with real D data using Tableau. The CHC then receives a population health data set that is regional. Of course, I don't think that includes patient information. And then also information about any additional resources available for addressing social needs in the region. Okay, that's all I have for review of the first two workshops, but I wanted to make sure that we highlighted the presentation from Rhode Island because I think it had a really great impact for the collaborative and we had a lot of excitement on it. Also, I think you all will be really interested to learn about the model in Rhode Island, the payment model and how Z codes fit into that. So we heard from two providers at a Rhode Island-based FQHC called Providence Community Health Center. Dr. Andrew Sell is the Chief Medical Officer and Dr. Jonathan Gates is the Chief Medical Officer for Accountable Care. Providence Community Health Center serves 60,000 patients across 8 clinics. 70% of them are on Medicaid, 10% uninsured, and 10% Medicare. They've been a Medicare ACO since 2014, and they've been a Medicaid ACO for about 4 years, since 2017. And that model is still evolving through risk sharing and total cost of care. They universally screen for housing instability, food insecurity, legal stressors, interpersonal violence, as well as depression, anxiety, and substance use. And they do this using an adapted version of Prepare in their EHR and crosswalking to Z codes on the back end. For a statewide metric, they measure and benchmark and report the social needs screening rate, but they've also created an internal incentive plan for clinicians and care teams to collect the data. Dr. Sell did go into more detail on strategies for responding to social needs and all of the community partnerships that they have. I left that out of highlights, but we can share the recording of this webinar after as well. So as a little bit of level setting, about half of our FQHCs in Oregon are on the APCM program, the Alternative Payment Care Methodology Program. And all of the participating FQHCs in this collaborative are on that program. Sorry, I have a cat that's being very disruptive. Okay, sorry. And really, Providence Community Health Centers created this arrow as a little bit of level setting, and they see themselves as really in that 1 foot in 2 canoes phase, whereas the Oregon FQHCs on the APCM program are in that highlighted purple one. And 1 foot in 2 canoes is really meant to mean that they're kind of bridging different models on the way to value-based care and working through different stages of risk sharing. So their big canoe is that they have shared savings under the PMPM model. And the smaller canoe is that they've started receiving quality payments from the state. So on this slide, this is their incentive model. They have their incentive. That smaller canoe is the quality score multiplier, which ends up being about 3% of their budget. Population risk scores at this point do not have any weight for Z codes in them, but they really made the point that they should, because social needs drive total cost of care, and the weight is absolutely there on the FQHC side, and they shared a lot of data to show that. So I have that to show you as well. And ultimately, their performance measures and total cost drivers end up being all-cause readmissions to the hospital, ER use in patients with mental illness, and avoidable ER use within their whole population. And to show this, they went into a lot of detail about cost drivers before and after the pandemic. So this is their screening data. Over the last year, they saw food insecurity increase 5-fold, housing insecurity increase 4-fold, and interpersonal violence double in their screening positives. And as they're pointing to hospitals and specialty visits really being the total cost driver, they broke that down into, they risk stratified for patients with social needs. So in that first blue bar, that's ER visits per 1,000 patients. In their whole population, they saw 38 ER visits per 1,000 patients. For any SUH finding in the chart, which is any combination of housing, employment, and food insecurity, that number went up to 297 per 1,000 patients. And then if pulling out only housing instability, that number was 204. So a Z code for homelessness predicted a 4-fold increase in utilization of the ER and inpatient admissions. And how that translated to cost. So in 2019, facility fees, meaning any ER, any hospital, for a patient with Z59.0 in their chart, that's the Z code for homelessness, an average per month with a patient with Z59 is $437. In 2020, that number average per month went up to $858. So at this point in the presentation, they went into data sharing. So this is definitely not my area of expertise, HIEs and CCDs, which I'll share more about in a moment. But the point that I think everyone took home is really that a reason that Rhode Island has been able to do a lot of this work is that they have a statewide HIE. And it's not perfect, but they are currently moving this data using CCDs to their statewide HIE. And a CCD is a continuity of care document. It's also sometimes called a clinical summary document. That's what's being used to share information with the statewide HIE. And this is generated at the end of every encounter in their EHR. And they've adapted this specific to their model. So they've adapted their the architecture of the CCD to include SUH data sets. They're also including vaccinations, labs, in addition to all of the other information at the end of the clinical encounter. Of course, the benefits of this are that it provides a more complete picture of a patient's risk in addition to what's being managed in that one encounter. And there's not as many bottlenecks. So in a standard claim, there's a limit of the amount of ICD-10 codes that are sent, and they're the ones that are being managed at that specific encounter. With a CCD, it's going to communicate all of the ICD-10 codes on a patient's chart. But they've also had to tweak them over time. So they had issues with the CCDs pulling in screening data that they had to resolve within their EHR. Their state HIE had to develop custom mapping of codes to Z codes for insurers. And then that same bottleneck issue that would generally happen on a claim is not happening with a CCD, but there's also some complications on having all of those ICD-10 codes included, despite potentially not having been managed at that encounter. And the points that they really wanted to drive home for the collaborative participants are that, of course, FQHCs have recognized and addressed social needs for generations, but they don't only matter from a public health perspective. They amplify total cost of care, and housing instability tends to be the biggest driver of cost, one of the largest ones. We're at a generational crossroads. Payer and state Medicaid goals are aligned with the FQHC mission at this point. And also alternative payment methodology means that all of the bells and whistles that generally wouldn't be in the budget are now a lot more important because they can help to reduce costs, including outreach, informatics, and care management. And then also, which is something we heard a lot in SDH metric development, is that social needs can only really partially be represented in Z codes. And really this is pointing to the lack of granularity of many Z codes, and also the fact that they can't communicate what the response to a need should be or how to meet one patient's specific needs, but they can be used to predict costs and utilization. Of course, it's not just about homelessness. Other social needs can have additive impact. And then another really interesting part of their presentation was they discussed how no-shows are correlated to total cost of care, and that PHQ-9 scores and no-shows are really strongly correlated. Again, if you want to see the recording and learn more about that one, I will send it out. And I mentioned before that we had really strong impact. So the collaborative participants were super engaged and had a lot of really great questions. We talked about from the FQHC side, at least, how should Z codes, what should their weight be in a risk adjustment model? The presenter's answer was really that they should be weighted as any other diagnosis through logistic regression analysis. And that, of course, things like homelessness are probably going to be a huge predictor of costs, even compared to other diagnoses. They are starting state-led to include race, ethnicity, and language as part of their risk model. There were a lot of questions about the homegrown screening tool because they are using many prepared questions, but adapted it to their own EHR and have other things in it. They were curious at how often Providence Community Health Centers is screening. They have adapted their EHR health reminders to be rolling back every 12 months. And then there was a lot of discussion about, how do we include this information in risk models if it's not being uniformly collected? And I think there's not a clear answer here other than to start uniformly collecting this information because we will only see where the light is. Okay, that was a lot of information quickly. Thank you for letting me breeze through that, but I would love to hear your thoughts. So we're going to do a waterfall chat. This is otherwise known as a chatterfall. And the way it works is you're going to type your response to this question in the chat, but you're going to wait to send. Don't hit send until I say so, because we're going to get everyone's responses at once. And someone always hits send early, so we'll all see you and we'll know it was you. That's okay, but try not to. And I'll give everyone a minute or so, maybe 90 seconds. Okay, I'm going to give it 15 more seconds.
You're right, Courtney. It feels like we need the Jeopardy sound during this.
I know, we do.
I
don't think. I was going to say you can sing it. I don't want to sing it.
I'll spare everyone from that.
Okay, go. And I invite you all to scroll through the responses. I'll read out some of them. So the impact of housing on costs, not a surprise, but resonated. Would have liked to see info about how they address the issue of houselessness. Yep. The lack of SDH data and its impact on our predictive modeling for risk and cost resonated with me, as this is our ongoing struggle and interest in Z codes for sure. Yeah, interested that Z59 was correlated with an average of $437 a month and almost double for the pandemic too. I wonder if that will continue going up or down or what we'll see. Social factors explaining a large part of risk, right? We say it all the time, but we don't necessarily get to see it in Oregon data. Data regarding SDH factors rising dramatically during the pandemic. Yeah. Okay, thank you, everyone. Kate, I thought you might be interested in the CCDs. That is definitely not my area of expertise, but I really invite you to watch that part of the webinar, and I can also reach out to them to answer any questions on how they've adapted that over time too. Okay, So I'm going to move on to the next slide. Does anyone have any burning questions before we move into workshop things? And I invite you to put that either in the chat or speak up too. Okay, cool. We'll have more time at the end for questions as well. So our May workshop and final workshop for this collaborative kicks off on May 5th. And we're going to have team presentations. I'll share more about those specific presentations and the questions we've asked in a moment. The second day, we are going to break all of the participants up into groups that they've chosen on the areas that they're most interested in and passionate about to answer questions about social needs screening at the system level. Then they'll come back for a third day on May 20th, and they'll have team presentations again. That'll be their final presentations for this collaborative. And then also they'll be repeating a baseline survey that they did for comparison to the beginning of the collaborative. There are a lot of questions in that about how frequently Z codes are being used, what the barriers still are, as well as CCO and F2HC relationship and knowledge about what the other does and the different factors that determine their decision making. So on the first day, we're asking for their data sharing templates. We want to see them and also track how they've changed over time throughout the last year. The number of individuals they've screened since July, the number of staff they have documenting Z codes, and also the number of positives for each of the Z codes that they chose, and the number of referrals. And then we've also asked that if they have explored risk stratification with Z codes, what they learned. We know that we had one team exploring Z codes with real D data and vaccination data. So I don't know where they got with that. I would love to see it, and maybe others have experimented as well. On the third day, they'll come back with 2 best practices from each team, what they should have done differently with the knowledge that they have now, whether they will or won't continue to use Z codes, and what their next steps are. Okay, so at this point, I'm going to invite you all to pull up a phone or another browser, and I'm going to stop sharing my screen so that Malia can share our poll. And the way that you use this, I think most of you have at this point, but you go to www.menti.com on either your smartphone or your computer, and you type in the code 67347460, and that's at the top. And Malia also put that in the chat. Thanks, Malia. So we should have 12 people participating, so I'll give it another moment. Okay, great, thank you. We've done this question at almost every call, but it's nice to see how it's changed over time. So as I was planning this workshop, one thing that came up kind of consistently for me is what is the messaging around the current OHA social needs screening metric development, and what should be emphasized and messaged to this group specifically. And I don't know if there's like a right or wrong answer to this, but really curious to see what your thoughts are. And this is an open-ended question too.
Which group are you referring to, Courtney, when you say to this group?
Oh, sure. Not us here on the call, but the group of collaborative participants. So we have everyone that has been piloting Z codes throughout the last year. And that's a group of 5 FQHCs and 3 CCOs, as well as some others who are kind of participating ad hoc.
Thanks.
Sure. How to stay updated, follow the tag meetings and share your thoughts and experience, definitely. We need more CBO voice. So maybe if they have partners that they've engaged in this work to elevate that. That it will keep evolving, that there'll be continued modifications. They can think about how the Z code work could help them with the metric. Should it be adopted? Definitely. I know this is not necessarily everyone's work, but it's related to some of you. Screening is imperative, and how to capture that data in a standard form is also critical for data collection. Sharing this across sectors. Importance of accurate data for driving policy and decision making. Yeah, definitely. And with this group too, I mean, actually looking at the data seems to have been the slowest aspect of the collaborative. We haven't asked for a lot of data from them, and hopefully Wednesday we get some. Advocate for metrics that are meaningful to you and that will actually matter in terms of improving health. Definitely. There's one more there. Our goal in developing the measure is to ensure that more CCO members have their needs acknowledged and addressed. We want input to help us refine the measure and meet that goal. Okay, thank you everyone for answering that. We'll move on to the next question. Okay, so this one, I think it'll be a little bit more difficult to see on this presentation as opposed to your phone or your computer. But these are the questions that were laid out in the beginning of the grant that we wanted participants to answer, we wanted to be able to answer. So on the second day, as I shared, we'll have really long breakout groups. The teams will each have a week with these questions, and then they'll have an hour together to answer these questions. But we're really curious about which ones you find to be the most important, what rises to the top, and maybe which ones we should spend some more time on or bring back answers to you all on in July. So no right or wrong answer, just what's sticking out to you. I know it's a lot to read. We'll take some time on this slide too.
Can you make it a little bit bigger? Like zoom in.
Malia, is it possible to zoom in on this slide? It's also, it should show up in a drop down as you're filling out the question. I trialed this on my phone and on my computer, and it was almost easier to read there than on this slide.
Weird. It's not showing up in my phone.
Chris, you may need to hit next question from the previous question that was what happened for me.
That was it. Thank you, Kate.
I just tried to make it a little bit bigger on my screen too. Hopefully that helps somewhat. We can just wait for a few more folks to get this question done, and then we can move on to the next one.
Yeah, I'm not seeing a ton more movement on this. So thank you. We will use this to decide which information to present back to you in July, and also that will help if there's extra time in the breakouts to know which ones that we should really be revisiting or emphasizing to participants in the homework. Thank you. We can go to the next one. So this is really related to the May workshop. This is our final workshop. This is really the first time that we are asking for data from the participants in the collaborative. This is also, in addition to those questions that we just looked at, this will be the first time we're asking them to make a decision about whether or not they will continue using them outside of the collaborative. This is the first time we're asking them for true best practices. But this will really be our last time to get information in. So feels like the stakes are a little bit higher on this one. So understanding next steps, will they continue the work? If so, and how? I think, yeah, definitely that's an important second question there is how, what's the sustainability of it as well? If they're prioritizing it and saying they're going to move it forward, how are they funding that if they're not getting an incentive, or what kind of staff capacity will they need? A recommendation for moving work forward. Would love to hear from them what they think is a logical next step to further develop this work. What would they say to other health centers or other CCOs that might be starting this journey? Information about how the data is being used. If any are planning to not continue with C-codes, what are they planning to do instead? It's a great question.
I'll give it a few more seconds in case anybody else has final things they're typing in, and then we can move on to the next one. All right.
So this question was really born out of response to the Mentimeter that we did at the last advisory call in in February. So we heard, that it would be helpful for the participants of this collaborative to be in a room with others. And in my mind, that includes some of you as well. So beyond the presentations that we have incorporated directly from participants into these meetings, would you like to engage with them at their final webinar where you could have all of them in the same room? Would you want to be listening in? Would you want to be part of that conversation? And we'll have one more question after this about the how there, but if that's something that you'd be interested in participating in, definitely let us know. Okay, so that seems like a mostly yes. So I think I will create a form after this to send out to all of you and figure out how we can make that discussion really worthwhile. But on the next slide, I wanted to try and gauge in what way, and you don't need to totally know the answer to this right now. We still have a few months, but especially if you would like to come present information at their webinar, that's something that we should be aware of, and maybe we can make that final webinar a little bit longer to give space for people to connect and present in that way. If it's just open space and discussion, we probably wouldn't add as much time to their final webinar. Or if you don't like either of those options, let us know or make a suggestion in the chat. I'm glad you're enjoying the Menti. I like this too.
I was just going to say too, I just saw what Catherine Potter put in about just listening in. And I was thinking I was almost going to type that in. I think I had said open space discussion, but I would also be interested in just listening, just learning and listening.
Okay, thank you. So I think this is our last question and we're almost finished. Looks like we'll get out about 10 minutes early. Thank you for participating in the Menti. And we have one more slide to show. It's really just about next steps and what to expect at this from here on out as we're wrapping up the collaborative. So Malia, it should be on the final one. Yes, thank you. So as we are in the last 3 months of the collaborative, we'll have this workshop throughout the month of May. In June, we'll bring all of the collaborative participants back for their final webinar from another state, as they just heard about the strategies for risk stratification using Z codes from the FQHC and clinic perspective. We'll be hearing from Community Health Plan of Washington about how they've risk adjusted for Z codes and their contracts. They probably won't share a ton of really specific information on their contracts, but we'll learn about their risk adjustment model and how they've weighted them. And then we'll have one more of these calls in July, as well as a final participant webinar in July. I think we'll have to think about whether or not we should combine them and do it all in one, or make them longer and have you tune into the second half instead. So we'll do some thinking about that. If you are thinking about that last question and say, you know what, no, I'd really love to share information about my work with these folks and give them an understanding of what I do and encourage them to reach out to me, or however you're thinking about that, just let me know. Send me an email and we'll get you on the agenda. And we have 12 minutes left. If you want to stay on and ask any more specific questions about the work we're doing with these folks at this time, please feel free to stay on. If not, thank you so much for joining, and I'm glad I could give you 10 minutes back.
Thank you. Bye.
Thank you so much.
Thank you.